Hand and wrist pain. It's a complaint that, well, it resonates deeply in nearly every clinic every single day, doesn't it?
Indeed, it does. Very common.
And all too often, our minds instinctively jump to that familiar diagnosis: carpal tunnel syndrome.
Hmm. The usual suspect.
Exactly. But what if the picture we're seeing is actually far more complex than it initially appears? What if what seems straightforward is, in fact, an intricate interplay of, subtle anatomical variations, maybe masquerading symptoms, and potentially multiple concurrent points of nerve compression, all creating a truly misleading clinical narrative?
That's precisely the challenge we often face.
Welcome to the Deep Dive Ortho, the show dedicated to extracting crucial, actionable insights from the cutting edge of orthopedic knowledge, designed specifically to sharpen your clinical acumen. Today, we have the distinct privilege of being joined by Professor Mo Imam, a true luminary in the field, who will guide us through a really fascinating and, dare I say, clinically vital topic.
Thank you for having me. It's a pleasure to be here.
Our deep dive today is into the intricate world of median nerve compression neuropathies. We're moving beyond the commonly known carpal tunnel syndrome to explore its often confused counterpart, pronator syndrome, and that particularly challenging phenomenon known as the double crush.
Yes, the double crush, a concept that explains a lot of persistent symptoms.
Our mission for this deep dive is really to illuminate the subtle yet absolutely critical distinctions between these conditions, offering you, our listeners, a clearer pathway for precise diagnosis and ultimately, well, far more effective treatment strategies. For you, our dedicated medical professionals, this deep dive aims to provide those genuine aha moments that will undoubtedly enhance your daily clinical practice and, most importantly, profoundly benefit your patients. We'll meticulously navigate the anatomical complexities, dissect the varied clinical presentations, evaluate the diagnostic tools at our disposal, and review the current treatment paradigms from initial conservative measures right through to advanced surgical interventions. So let's begin our exploration.
Okay, let's unpack this intricate topic then. Before we delve into the syndromes themselves, it's absolutely crucial, I think, to truly grasp the median nerve's rather extraordinary anatomical journey. Professor Imam, where does this vital nerve begin its remarkable descent, and what are the key, almost notorious landmarks it traverses on its way down the arm that we, as clinicians, really need to be acutely aware of?
Thank you. Well, the median nerve embarks on quite a complex and frankly vulnerable path.
Yeah.
It originates from the C5 to T1 nerve roots, right up within the brachial plexus in the neck.
Okay.
From there, it descends through the upper arm, initially running very closely alongside the brachial artery. As it continues its journey downwards, it strategically passes between the biceps brachii and brachialis muscles. That's a point where it can be subtly compromised, actually.
Right.
As it reaches the antecubital fossa that's from front of the elbow, it then travels deep to a highly significant fibrous structure, the bicipital aponeurosis, or as we often call it, the Lacertus fibrosis.
Ah, yes, the Lacertus fibrosis.
Exactly, and it remains anterior to the brachialis muscle at that point.
Okay.
Now, once it gets past the elbow, its course into the forearm becomes highly relevant to our discussion today. This is precisely where numerous potential compression points emerge, each one capable of creating a unique set of symptoms.
The real danger zone, perhaps.
You could say that. It most commonly navigates its way between the humeral, that's the superficial, and the ulnar, the deep, heads of the pronator. Carries muscle, a muscle whose very name, of course, gives away its significance in one of our conditions.
Pronator syndrome, yes.
Precisely. Further distally, it descends deep to the two heads of the flexor digitorum superficialis, a muscle we'll definitely come back to, and continues its journey down into the forearm, nestled quite intimately between the flexor digitorum profundus and the flexor digitorum superficialis.
So it's really weaving its way through quite a few structures there.
It is indeed. Near the wrist, near the retinaculum flexorum, it positions itself lateral to the flexor digitorum superficialis muscle before ultimately passing into the palm, its final destination. It's truly a long and winding and indeed quite susceptible road for this nerve.
That detailed journey truly highlights why it's so vulnerable at multiple points. It really is like a long, winding road with potential bottlenecks around every corner, isn't it?
That's a very good analogy.
Now, taking that anatomical roadmap, how do these various points of compression translate into the diverse and often confusing clinical pictures we see in our patients? How do we start to differentiate the wrist culprit from the forearm imposter? But before we get right there, let's drill down into those specific choke points you just mentioned in the proximal forearm. It's clearly not just one spot, is it?
No, absolutely not.
Can you walk us through the specific anatomical structures there that can cause this nerve to be compressed, leading to these varied symptoms?
Absolutely. The very anatomy of this region predisposes the median nerve to compression at several distinct points. And that's precisely why differentiating these syndromes is such a challenge for us clinicians. It's often not about one obvious anatomical problem, but more of an interplay.
Right.
So firstly, we have the ligament of Struthers and the supracondylar process. Now, this is a fibrous band, and it's quite rare, actually, present in only about 1% to 2% of the population.
Only 1 or 2%?
Yes, very low. It extends from a bony spur, the supracondylar process, located in the distal humerus, right down to the medial epicondyle. Both the median nerve and the brachial artery can pass beneath it, making it a critical site of potential compression.
So a double whammy, potentially.
Potentially, yes. While rare, when it's present, it creates a very distinct, often acute, compression point. For patients with symptoms clearly attributable to this structure, complete and often quite dramatic relief can be achieved by surgically releasing the nerve in this specific area. The key here is recognizing its potential presence, especially in cases presenting with atypical pain patterns in the upper arm or elbow.
Okay, so that's the first one, albeit rare. What's next?
Next along the path is the Lacertus fibrosus,
Yeah.
also known, as we mentioned, as the bicipital aponeurosis.
Huh.
This is a robust fascial extension originating from the biceps tendon. It crosses obliquely over the antecubital fossa, lying directly anterior to the median nerve.
Right over the top.
Exactly. Now, here's where it gets truly interesting from a clinical perspective. Passive pronation of the forearm, or even just sustained elbow flexion, can cause the biceps tendon to tighten, dragging on this Lacertus fibrosus structure and directly compressing the median nerve underneath.
Ah, so movement can trigger it.
Precisely. And research indicates that this structure can be thickened in up to 70% of upper limbs.
70%, that's high.
It is surprisingly high. And in a significant proportion of those cases, about 64%, it lies directly over the median nerve, making it a common but often overlooked anatomical variant causing issues.
Wow.
What's particularly noteworthy, and this is a real aha moment for clinicians, I think, is that acute compression of the median nerve at the elbow by the Lacertus fibrosus has been observed following specific elbow injuries, like a partial rupture of the biceps brachymyotendinous junction.
After an injury.
Yes. In such instances, surgical decompression has yielded immediate and complete relief of symptoms, which is a powerful demonstration of a direct mechanical cause and effect. There's even evidence suggesting a bilateral predisposition for Lacertus fibrosis entrapment.
Meaning if you find it on one side.
You should certainly consider the possibility on the other side, prompting us to consider it more broadly in the patient's history and examination.
Fascinating. Okay, so ligament of Struthers, Lacertus fibrosis, what else?
Then we arrive at the pronator teres, PT muscle. This is, by definition, the muscle from which pronator syndrome derives its name, and it's repeatedly observed as the most common cause of compression in that syndrome.
The prime suspect.
Indeed. It contributes to anywhere from 33% to a staggering 76% of pronator syndrome cases. The median nerve typically passes between its two heads, the humeral, or superficial, and the ulnar, or deep head.
Okay.
However, anatomical variations are quite common here. For instance, the ulnar head can be absent in up to 45% of the population, sometimes replaced by a distinct fiber structure, which can cause issues.
So nearly half might not have that typical anatomy.
Correct. And compression can also occur due to thickened intramuscular tenderness and fibrous bands within the muscle itself, or if the humeral head originates more than 2 centimeters proximal to the medial epicondyle, effectively creating a tighter, more acute space for the nerve to pass through.
Right.
Clinically, you can often palpate the pronator teres about 6 centimeters distal to the elbow crease and 4 centimeters lateral to the medial epicondyle. Eliciting tenderness here is a key diagnostic clue for potential involvement.
Good landmark to remember. Okay, pronator teres. Are there more?
Yes, further distally, we encounter the flexor digitorum superficialis, FDS, fibrous arch. This is another significant compression point. Just distal to the pronator teres, the median nerve can be compressed by the fibrous leading edge of the FDS muscle, particularly as it forms an aponeurotic arch.
An archway it has to pass under.
Exactly. And this can affect both the main median nerve and its crucial branch, the anterior interosseous nerve, which we'll touch on. Even simple elbow extension can induce compression at this site in some individuals, which really means a careful history of provoking activities is essential.
So just straightening the arm could cause symptoms for some.
For some, yes. Variations within the FDS muscle and its tendons can also cause intermittent median nerve compression, making it potentially a dynamic rather than a static entrapment problem.
Okay, FDS arch. That covers the main ones.
Those are the most common proximal sites. But while less frequent, it's important to mention other, rarer sites of median nerve compression. These can include structures like the accessory head of the flexor pollicis longus, sometimes called the Ganser muscle,
Ganser muscle, right.
which, though often asymptomatic, can become hypertrophied with repetitive gripping or forceful thumb use and cause compression. We've also seen cases involving networks of aberrant blood vessels that cross the median nerve, creating a sort of pulsating compression, or even subtle exostosis of the radius from prior trauma, creating a dynamic pinch point during movement.
So old injuries could play a role.
They certainly could. In atypical presentations, or when the more common sites have been ruled out, these rarer anatomical variations become crucial to consider. They often require high-resolution imaging to visualize, as they might just be the overlooked piece of the puzzle.
It really highlights the need for thoroughness.
Absolutely. And it's also worth specifically noting the anterior interosseous nerve, or AIM. This is a purely motor branch of the median nerve. It can be particularly susceptible to compression near its origin, typically just after it branches off the median nerve, often by that FDS arch, or even an anomalous muscle like the Ganser.
Purely motor, you said.
Yes, purely motor, so its dysfunction presents differently, primarily with profound muscle weakness affecting the flexor pollicis longus, the thumb flexor, and the flexor digitorum profundus to the index, and sometimes middle fingers, rather than sensory changes.
No numbness or tingling with AIN.
Typically not. The classic sign is an inability to make the OK sign because they can't flex the tip of the thumb and index finger properly. That distinction is paramount.
That's a really clear distinction. Okay, that level of anatomical detail is incredibly helpful, truly painting a picture of all these potential bottlenecks. It really underscores why a meticulous physical examination is just so vital, doesn't it?
It really does.
So, taking that anatomical blueprint, how do these various points of compression translate into the diverse and often confusing clinical pictures we see? How do we begin to differentiate the wrist culprit, carpal tunnel syndrome, from the forearm imposter, pronator syndrome? Because they do share symptoms, making it an ongoing diagnostic dilemma, don't they?
Indeed, they do share symptoms, and that's the crux of the issue. What's truly fascinating here, and a critical point for all clinicians, is that while both carpal tunnel syndrome and pronator syndrome are median nerve entrapment neuropathies, their distinct anatomical locations lead to subtle yet significant differences in presentation. And these nuances are absolutely key to correct diagnosis and avoiding the pitfalls of misattribution.
Okay, so let's break down those differences. Let's start with carpal tunnel.
Right. Let's start with carpal tunnel syndrome, CTS, the classic wrist culprit. Patients typically report tingling, numbness, and pain, primarily in the thumb, index, and middle fingers, sometimes the radial half of the ring finger, too. The pain can sometimes radiate proximally up into the forearm or even the shoulder, which can sometimes cause confusion.
That proximal radiation can muddy the waters a bit.
It can. But here's a true hallmark symptom, often not seen in isolated pronator syndrome, the worsening of symptoms at night. Patients frequently report being woken from sleep by the numbness or pain.
That nocturnal worsening is really key then.
It's a very strong indicator for CTS. It's often due to fluid shifts and increased pressure within the carpal tunnel when the wrist is held in a flexed position during sleep, leading to further nerve ischemia.
Makes sense. And what causes the pressure increase in the first place?
Well, the etiology of CTS arises from increased pressure within that confined carpal tunnel space, and the causes are often multifactorial. We tend to categorize these into local, regional, and systemic causes.
Okay.
Local causes include things like tenosynovitis, which is inflammation of the flexor tendon sheaths within the tunnel, trauma, such as collis fractures or carpal bone dislocations, which can directly reduce the tunnel's volume, various space-occupying lesions like lipomas or ganglia, and anatomical anomalies like abnormal muscle bellies extending into the tunnel, or simply a thickened transverse carpal ligament.
Things right there at the wrist.
Exactly. Then you have regional causes, which might involve conditions like osteoarthritis or rheumatoid arthritis, causing synovial proliferation, or amyloidosis and gout, leading to depositions within the tunnel. And then there are the broader systemic causes. This encompasses a wide range of conditions, including diabetes, a very common association, obesity, hypothyroidism, pregnancy, menopause, systemic lupus erythematosus, scleroderma, dermatomyositis, renal failure, long-term hemodialysis, acromegaly, multiple myeloma, sarcoidosis, leukemia, alcoholism, even hemophilia.
That's quite a list. It really highlights the connection to overall health.
It really does. Interestingly, the presence of a persistent median artery, an anatomical variant, has also been identified as a factor in about 2.8% of cases. But the real aha here, I think, is recognizing how a patient's underlying systemic health, say poorly controlled diabetes, dramatically changes the nerve's baseline vulnerability. It's not just a cause, it acts as a sensitizer.
As sensitized.
Yes, it makes the nerve more prone to compression and often less likely to recover well post-intervention, which significantly impacts our prognosis and how we counsel patients.
It's a very important perspective.
Looking at contributing factors, CTS accounts for up to 62% of reported occupational diseases. Although the precise link to repetitive work with high forces remains somewhat inconsistent in the literature, suggesting it's likely a combination of factors at play.
So work activity might contribute, but it's not always the sole cause.
Correct. High body mass index and unhealthy lifestyle habits, including alcohol, tobacco, caffeine consumption, are also correlated, as they can contribute to inflammation or metabolic disturbances affecting nerve health. While the exam pathogenesis isn't fully clear, the hypothesis is that mechanical compression leads to local ischemia and demyelination of nerve fibers, with sensory fibers usually affected before the motor fibers.
Sensory first, then motor?
Typically, yes. And a genetic predisposition can also be suspected in cases of early onset, familial occurrence, or bilateral symptoms. Some people just have smaller tunnels or ligaments more prone to thickening.
Okay, that gives us a good picture of CTS. Now let's turn to the forearm imposter pronator syndrome. How does that present differently?
Right, pronator syndrome, PS. Patients most commonly describe an aching pain in the proximal forearm, often accompanied by paresthesias, tingling, or numbness in the median nerve distribution, similar to CTS in that respect.
So the location of the pain is often more proximal.
Often, yes, the ache is predominantly in the forearm. And here's a crucial distinguishing feature from CTS, a key point for your diagnostic checklist. The typical absence of nocturnal awakening.
No waking up at night.
Generally, no. Symptoms are often provoked by activity, particularly persistent elbow flexion, forearm supination, forearm pronation, or repetitive grasping, think using a screwdriver, carrying heavy bags, or performing repetitive weightlifting.
Activity-related forearm pain.
Exactly. While less common, some patients may report numbness in the volar radial 3.5 fingers and, importantly, the ulnar eminence, that fleshy part at the base of the thumb.
And that's different from CTS.
Yes, that's a key detail for differential diagnosis. The palmar cutaneous branch of the median nerve, which supplies the thenar eminence, typically branches off proximal to the carpal tunnel. Therefore, it isn't usually affected by isolated carpal tunnel compression. Its involvement immediately points towards a more proximal issue like PS.
That's a fantastic clinical pearl.
It really helps differentiate. Now, it's important to note the incidence here. PS is a much rarer condition than CTS, diagnosed in only about 1.1% of all upper extremity compressive neuropathies.
Much rarer.
Much rarer. However, and this is where it becomes a frequent clinical challenge, it's a common culprit in misdiagnosis. It accounts for 32% to 49% of cases initially mistaken for CPS, often leading to unsuccessful carpal tunnel decompression procedures.
So almost half of presumed CTS failures might actually be PS.
It's certainly a significant proportion, which highlights why this differentiation is so vital, both for patient outcomes and avoiding unnecessary surgeries.
Absolutely critical. So given these subtle differences, the physical exam must be paramount.
It truly is. Physical examination remains the cornerstone for diagnosing both conditions, allowing us to try and pinpoint the probable site of compression. No amount of imaging can replace a thorough clinical assessment here.
Okay, walk us through the key exam findings for PS.
For pronator syndrome, you should meticulously palpate the proximal forearm, searching for tenderness, specifically over the course of the median nerve. An indentation of the flexor pronator mass just below the medial epicondyle might specifically suggest Lacertus fibrosis compression.
Feeling for that specific spot?
Yes. Then the pronator compression test is highly suggestive. You apply sustained, firm pressure for about 30 seconds directly over the pronator teres muscle along the median nerve's likely trajectory, typically about 6 centimeters distal to the medial epicondyle. This maneuver aims to provoke the patient's familiar paresthesias or pain. It's often positive in surgically confirmed PS cases and, importantly, typically negative in isolated CTS.
A provocative test specific to the pronator area.
Exactly. And provocative forearm movements can further help isolate the specific compression site. For instance, to test the pronator teres, Have the patient actively pronate their forearm against your resistance, keeping their elbow flexed somewhere between 0 and 45 degrees. Increased pain or paresthesia suggests median nerve compression against the PT muscle itself.
Okay.
To test the Lacertus fibrosus, have the patient flex their elbow from about 100 to 135 degrees against your resistance during both elbow flexion and forearm supination. Concurrent paresthesia strongly suggests Lacertus fibrosis involvement is the culprit.
Resisted flexion and supination for the Lacertus.
Correct. Now, testing the flexor digitorum superficialis by resisting middle finger proximal interphalangeal joint flexion is generally considered less reliable,
Why is that?
because that FDS contraction can inadvertently draw the lumbrical muscles down into the carpal tunnel itself. This can then create or exacerbate symptoms at the wrist, thereby obscuring whether the primary issue is the proximal FDS arch or actually something happening in the carpal tunnel.
Ah, so it can give a false positive for proximal compression.
Potentially, yes. It means relying too heavily on a positive FDS test in isolation can lead us down the wrong diagnostic path. It really emphasizes that no single test exists in a vacuum. It's the constellation of findings that guides us.
Got it.
Crucially, CTS-specific tests, like the Tinel sign tapped at the wrist, Phelan's wrist flexion test, and carpal tunnel compression tests, like Durkin's test, are often negative in isolated pronator syndrome.
So if those wrist tests are negative, but forearm tests are positive.
Exactly, that pushes you towards PS. And the presence of numbness, the thenar eminence, as we mentioned, is significantly more common in PS and usually absent in CTS, another key differentiator.
Okay, that's clear for PS. What about the exam for CTS?
For carpal tunnel syndrome, patients may present with weakness and, in later stages, visible atrophy of the thenar muscles, alongside that characteristic sensory loss in the affected fingers. The Tinel sign at the wrist-like percussion over the median nerve at the carpal tunnel, inducing paresthesias distally, is a classic finding, though not perfectly sensitive or specific.
The tapping test.
Yes. The Phelan test, involving complete unforced wrist flexion for 1 minute, aims to elicit the patient's typical paresthesias. And the carpal tunnel compression test, often called the Durkin test, involves applying direct pressure over the carpal region for about 30 seconds, which often leads to a rapid manifestation of CTS symptoms if positive.
Direct pressure over the tunnel.
Correct. While objective motor deficits can be minimal initially, remember, sensory fibers are often affected. First, careful, thorough individual muscle testing, comparing strength to the unaffected side, is imperative. This includes assessing the abductor pollicis brevis, part of the NR eminence, the flexor pollicis longus, FPL, the flexor digitorum profundus, FDP, to the index and middle fingers, and the flexor carpi radialis. Muscle fatigue tends to be more common in PS, whereas clear thenar atrophy is more indicative of long-standing or severe CTS.
That's a truly invaluable breakdown of the clinical examination. It really underscores how much we still rely on the art and precision of the physical exam, especially when dealing with such subtle distinctions.
Absolutely. The hands-on assessment is irreplaceable.
So building on that, how do electrophysiological studies, EDX, and imaging complement our physical examination? Are they the definitive arbiters, or do they serve more as crucial supporting characters in our diagnostic drama?
That's a great way to put it, supporting characters. Neurophysiological methods are indeed invaluable, particularly for distinguishing these conditions, but their interpretation requires very careful clinical correlation. They aren't always the final word.
Okay.
For pronator syndrome, electrodiagnostic, or EDX, studies are typically negative or inconclusive, especially in the early stages or when the compression is intermittent or dynamic, perhaps related to specific postures or activities.
So a normal EDX doesn't rule out PS.
Absolutely not.
Mm-hmm.
A positive result might show decreased conduction velocities from the elbow down to the wrist, but often the changes aren't as clear-cut as we see in CTS because the compression isn't always constant. This isn't a failure of the test itself. Rather, it's a powerful reminder that clinical acumen and a meticulous physical exam remain paramount, even in our age of advanced diagnostics.
Clinical suspicion trumps a negative test sometimes.
In the case of PS, often, yes. In contrast, carpal tunnel syndrome usually presents with a positive EDX, showing clear decreased conduction velocity across the carpal tunnel, particularly noted at the mid-palm segment, and often prolonged distal motor and sensory latencies. It's usually much more definitive for CTS.
More clear-cut findings at the wrist.
Generally, yes. For anterior interosseous nerve syndrome, which, as we discussed, is purely motor EDX, can often confirm the diagnosis in 80% to 90% of cases. It reveals specific denervation patterns in muscles like the flexor pollicis longus, the flexor digitorum profundus to the index finger, and the pronator quadratus muscle in the distal forearm.
So EDX is very helpful for Annian syndrome.
Very helpful indeed.
Okay, what about imaging? Ultrasound or MRI?
Moving to imaging. For CTS, high-resolution ultrasonography, or US, can be highly useful, especially when clinical findings are quite consistent. But perhaps EDX is normal or equivocal.
Ultrasound for CTS.
Yes. It can reveal thickening or edema of the median nerve right at the carpal tunnel entrance, often quantified by measuring its cross-sectional area and also flattening of the nerve itself under the ligament, providing objective visual evidence of compression.
So you can actually see the nerve being squashed.
You often can, yes.
Yeah.
For pronator syndrome, however, both US and MRI are generally not recommended as primary diagnostic tools. This is mainly due to a lack of robust clinical evidence showing consistent, reliable findings across patients.
Less useful for PS, then.
Generally less useful as a primary tool, though ultrasound can sometimes visualize the compression site, for example, between the pronator chair's heads, or it might identify other rarer causes, like a vessel or ganglion cyst. So it could be a useful adjunct for specific localized investigation when your clinical suspicion remains high despite negative EDX, or if you suspect one of those rarer causes.
So more targeted use for imaging in PS.
Precisely. Insights from recent studies, like the one by Shields and colleagues, have highlighted the value of a tiered diagnostic approach for these proximal median nerve neuropathies, adding another layer to our understanding. This particular study classified these neuropathies into 4 distinct zones based on the level of involvement, stretching from the brachial plexus right down to the distal forearm. They found that iatrogenic injury, say, from previous shoulder surgery or a brachial artery puncture during a procedure, was actually the most common cause in the most proximal zone, Zone 1.
Injury caused by treatment itself.
Yes, emphasizing the importance of a thorough patient history, including past procedures, whereas non-iatrogenic trauma, like deep lacerations or direct contusions, was more common in the more distal forearm zone, which they designated Zone 4.
Right.
For cases involving the AIN, or Zone 3 Parsonage-Turner syndrome, which is an acute brachial plexopathy, an inflammatory condition was found to be a frequent etiology, highlighting the need to consider neurological conditions beyond simple mechanical compression.
So not always just a squeeze.
Not always. The study also demonstrated that ultrasound was invaluable in helping localize lesions, especially where EDX might be challenging, for instance, with very proximal lesions high in the arm, or very distal ones affecting only small sensory fascicles, which might not show up clearly on routine nerve conduction studies.
Ultrasound helping where EDX struggles.
Exactly. Furthermore, US could sometimes help differentiate between nerve injury types, such as neuromesis, a complete severance of the nerve requiring surgical repair, and axonotmesis, damage to the axons, but with preservation of the nerve sheath, which has better potential for spontaneous recovery. This distinction is absolutely critical for guiding prognosis and management decisions, influencing whether surgical repair or expectant management is the appropriate path.
That's incredibly useful information. Okay, this concept of the double crush or even multiple crush syndromes is something that truly resonates as a critical consideration. It feels like it adds a whole new layer of complexity to our diagnostic thinking, doesn't it?
It absolutely does. It complicates the picture significantly sometimes.
Can you explain why it's such a crucial consideration, especially in the context of these median nerve compressions, and perhaps more importantly, how does it really impact our patient outcomes?
Well, it adds complexity, but understanding it is key. What's truly fascinating here, and it's a fundamental principle in peripheral nerve pathology, is the understanding that a nerve, when compressed at one anatomical location, becomes inherently more vulnerable or susceptible to compression at another, often quite distant site along its course.
So one problem makes it easier to get another one.
Precisely. This double crush hypothesis, first proposed way back in the early 1970s by Upton and Bokomas, was quite revolutionary at the time. They observed patients who had seemingly mild proximal lesions, maybe a bit of neck root irritation, developing surprisingly severe distal symptoms, like classic carpal tunnel syndrome. They posited that a subclinical compression at one site somehow sensitized the nerve to another compression elsewhere.
Right.
Subsequent research, particularly with modern imaging and neurophysiological techniques, has refined our understanding. It shows how this initial compression can actually alter axoplasmic flow, that's the vital transport system for nutrients and proteins within the nerve axon, and reduce the transport of crucial neurotrophic substances which are essential for nerve health and repair.
So it disrupts the nerve's internal supply chain.
Exactly. This essentially makes the nerve more fragile and less resilient to further stress or even a second, seemingly minor compression elsewhere. It's like, as you suggested earlier, a bottleneck in a plumbing system. A small blockage upstream makes the whole system much more sensitive to another small blockage downstream.
That makes intuitive sense.
And this principle is incredibly relevant in our clinical practice, particularly because carpal tunnel syndrome is so prevalent. It's not uncommon for a patient to present with symptoms that appear to be solely CTS, but in reality, a coexisting pronator syndrome is also contributing, or perhaps even primarily causing, some of the symptoms that are being mistakenly attributed solely to the wrist.
The forearm issue gets missed because the wrist is so common.
Very often, yes. There's even a concept of reverse double crush, suggesting that a distal compression like CTS can potentially predispose the nerve to developing proximal issues and symptoms as well, illustrating the complex bidirectional interplay along the nerve's entire course. This really means we must always look at the nerve's health along its entire length, not just at the site of maximal symptoms.
Thinking proximally and distally.
Always. Furthermore, it's vital to recognize that not all crushes are purely anatomical pinch points. Broader systemic factors that impair overall nerve health, things like smoking, excessive alcohol consumption, diabetes, thyroid disease, these can also act as independent crushes in physiological sense.
Systemic factors as crushes.
Yes, they contribute cumulatively to a patient's symptomatology by making the nerve generally more vulnerable everywhere. For example, a patient with long-standing, perhaps poorly controlled diabetes might have a subclinical polyneuropathy. When that's combined with even mild anatomical compression at the wrist or elbow, it can lead to pronounced symptoms that might otherwise not have been present or would have been much milder. This comprehensive view of nerve health is paramount. We need to move beyond just looking at the immediate anatomical compression to consider all the systemic influences that might be at play.
That's a really holistic view. So what are the clinical implications of missing this, of overlooking a concurrent compression?
The implications are significant, and this is where the aha moment often arrives. Sometimes, unfortunately, after an initial treatment hasn't worked as expected. If a coexisting pronator syndrome is missed during the diagnostic process, especially when carpal tunnel syndrome seems more obvious and is readily identified, the patient may undergo a carpal tunnel release surgery.
The standard procedure?
Exactly. Only to find that their symptoms are not fully relieved, or worse, they persist largely unchanged. This obviously leads to persistent pain, ongoing paresthesias, significant patient dissatisfaction, and the need for further investigations and potentially additional surgical interventions, which is frustrating and costly for everyone involved.
The failed carpal tunnel release scenario.
Precisely. And studies indeed show that pronator syndrome is a common reason for this, sometimes only identified after a seemingly failed CTS decompression. Imagine, for instance, a patient, perhaps a 50-year-old office worker, who has classic wrist pain and numbness, particularly at night. They undergo carpal tunnel release. But a month later, they still complain of this vague forearm aching and intermittent numbness that perhaps extends higher up their palm, maybe even including that thenar eminence. That's your big red flag.
The red flag to look higher up.
Exactly. That's your cue to reevaluate for a proximal compression, like PS, because the initial solution might have only addressed half the problem.
Okay, so how do we actively look for these combined syndromes? What are the key diagnostic clues?
We rely on specific clues. For patients presenting with typical median nerve distribution, pain and tingling, that is, in the thumb, index, and middle fingers, the presence of paresthesia involving both the thenar eminence and the proximal forearm should strongly guide the diagnosis towards considering a combined CTS and PS.
The thenar eminence numbness again.
Yes, it's a very important distinguishing feature. Remember, that area gets its sensation from the palmar cutaneous branch, which usually comes off proximal to the carpal tunnel. So its involvement immediately points to an issue proximal to the wrist or potentially a double crush involving both levels.
Okay, that's one key clue. What else?
Another critical differentiator for you, our listeners. While nocturnal paresthesia, waking from sleep, is a hallmark symptom of isolated carpal tunnel syndrome.
The night pain we discussed.
Yes, it is typically absent in isolated pronator syndrome. Therefore, if a patient whom you suspect has pronator syndrome also reports significant nocturnal symptoms, that is a strong indicator to also consider coexisting carpal tunnel syndrome and investigate the wrist level thoroughly. It's a key sign that something more might be going on at the wrist as well.
So night pain and suspected PS means look at the wrist too.
Absolutely. It's a strong indicator for a potential double crush. To systematically approach a diagnosis in these complex double crush scenarios, having a diagnostic framework is invaluable. Key inclusion criteria for seriously considering concurrent CTS and PS might include classic clinical signs of CTS, like positive phalans or tennals at the wrist, paresthesia over the palm's median nerve innervation, including the thenar eminence, notable forearm muscle pain and tenderness, especially over the pronator teres, and D, positive results on both the wrist provocation tests, phalan stenols, and the pronator teres provocation test.
Positive tests at both levels.
Yes, positive findings at both locations significantly increases your suspicion for a double crush phenomenon.
Makes sense. And of course, rule out other things first.
Absolutely essential. Before confirming a double crush diagnosis, you must systematically exclude other conditions that can mimic median nerve compression. These include thoracic outlet compression syndrome, which often involves the entire brachial plexus, and might have vascular symptoms like coolness or color change. Peripheral polyneuropathies, typically bilateral, symmetrical, and often affecting feet as well. Cervical radiculopathy, usually presenting with neck pain radiating down the arm, often exacerbated by neck movements, and following a specific dermatomal pattern that usually doesn't perfectly match the median nerve distribution.
Like C6 or C7 patterns.
Exactly. And then rarer things like stroke, which would present with much broader neurological deficits or considering previous significant injuries to the affected limb or spine. A thorough differential diagnosis is always a must. Leave no stone unturned before landing on double crush.
Okay, so if we do establish a concurrent diagnosis of CTS and PS, how does that change the treatment strategy?
Well, if we connect this to the bigger picture, once that concurrent diagnosis is established, the treatment strategy really needs to be comprehensive and target both sites of compression.
Address both problems.
Yes. Unfortunately, due to the relatively low prevalence of these proven concurrent cases, and frankly, limited supporting high-level scientific data, there aren't universally accepted standardized treatment algorithms that dictate the exact order or type of intervention. Should you release the wrist first? The forearm first? Both together? The evidence isn't definitive yet.
No clear guidelines.
Not universally agreed ones, no. However, the most commonly acknowledged and generally effective treatment strategy reported for these confirmed combined conditions is invasive, meaning surgical.
Surgery is usually needed for double crush.
Often, yes, especially if conservative measures targeting both areas have failed. Research has explored simultaneous surgical approaches. For example, performing an arthroscopic release of the transverse carpal ligament at the wrist combined with an open decompression of the pronator teres muscle and other potential proximal sites in the forearm, all in the same operation.
Doing both at once.
Yes. For patients undergoing surgery for the first time with this established combined diagnosis, this simultaneous approach has actually shown very good outcomes in several studies, with reports showing a high percentage of patients achieving complete or near complete relief of both pain and paresthesias. This provides a strong argument for getting that thorough initial diagnosis right, so you can potentially address both problems in one go if needed. Get it right the first time.
Saves the patient another surgery, potentially.
Exactly. Furthermore, and this is crucial for those challenging cases where maybe the double crush wasn't initially recognized, for patients who've already undergone a primary CTS surgery but continue to experience significant symptoms, and a coexisting pronator syndrome is then suspected and confirmed.
The failed CTS release group.
Yes. Studies indicate that performing a simultaneous release of both the transverse carpal ligament, often a revision release, and the pronator muscle and other proximal sites leads to significantly better chances of full recovery from numbness and pain, and also improved grip strength compared to just doing a repeat carpal tunnel release alone.
So even if CTS surgery failed, addressing the proximal issue helps.
Significantly. It reinforces the need for that thorough diagnostic precision right from the outset to avoid these recurrent issues and ensure optimal patient satisfaction, preventing that frustrating cycle of failed interventions.
So we've meticulously navigated the diagnostic complexities, delving into the anatomical nuances, the clinical distinctions, and that challenging double crush conundrum. What's next for our patients once a median nerve compression syndrome or even a double crush has been clearly identified? How do we approach treatment, starting from initial conservative management right through to when surgical intervention becomes necessary, and what can our patients realistically expect?
Right. Moving on to management. Whether it's carpal tunnel syndrome, pronator syndrome, or indeed a combination, the initial approach typically involves a period of dedicated conservative management. The decision to escalate to surgery is then carefully weighed based on the severity of symptoms, the patient's response or lack thereof to non-operative treatment, and of course, any objective clinical findings of nerve damage, such as progressive muscle weakness or visible atrophy.
Conservative first, unless there are red flags.
Generally, yes. For both Kronecker syndrome and carpal tunnel syndrome, an initial period of conservative therapy, often lasting somewhere between 3 to 6 months, is commonly chosen and appropriate. Clinical data actually shows a significant rate of improvement with conservative measures alone, ranging from perhaps 29% up to 80% for PS cases managed conservatively in some series. So it's always worth starting here, unless there are clear indications for immediate surgery, like profound weakness or acute injury.
So a good chance conservative treatment might work.
A reasonable chance, yes. The core components of conservative management are quite similar for both conditions, though there might be slight variations in application depending on the primary site suspected. Activity modification is paramount.
Changing what they do.
Absolutely. Patients are advised to identify and modify activities that clearly exacerbate their symptoms. For PS, this might be repetitive elbow flexion, forearm pronation, forceful gripping. For CTS, prolonged wrist flexion or extension, or forceful gripping. This can range from simply diminishing strenuous activities to complete cessation for a defined period.
Like taking a break from certain tasks.
Exactly. For instance, for a patient with PS, this might mean avoiding prolonged driving with bent elbows, trying to keep the arm straighter, or switching to tools that require less forceful forearm rotation. Job modifications, like altering elbow or forearm position during tasks, using ergonomic keyboards or mouse setups, and incorporating frequent breaks to perhaps supinate the forearm for PS, or stretch the wrist for CTS, especially for computer-based work, can be highly effective and are often overlooked by patients until specifically pointed out.
Simple changes can make a big difference.
They really can. Rest and splinting are also key components. For CTS, wrist splinting is a very common and often effective conservative therapy. Wearing a neutral wrist splint, particularly at night for perhaps a 3-month period, can significantly improve hemodynamic parameters within the carpal tunnel by reducing pressure, reducing edema, and minimizing nerve friction by keeping the wrist in that neutral open position.
Night splinting for CTS.
Yes, it's notably recommended during pregnancy, where fluid retention often exacerbates symptoms and surgery is less desirable. While some patients may report benefit from full-time splint use, there's actually no clear evidence that it's superior to night-only splinting for most people. For PS, an elbow splint, usually holding the elbow in slight flexion and the forearm perhaps in neutral rotation, may be considered, though its evidence base is not as strong or well-established as wrist splinting is for CTS.
Okay, splinting mainly for CTS then. What about medications?
In terms of pharmacological interventions, medications and local injections are options. Non-steroidal anti-inflammatory drugs, NSAIDs, can be used for managing pain and perhaps reducing associated inflammation, though their direct impact on the nerve compression itself is likely limited.
Pain relief, mainly.
Yes. Local injections of corticosteroids, sometimes mixed with a local anesthetic, into the affected area are also a common option. For CTS, this means an injection directly into the carpal tunnel. For pronator syndrome, the injection would be targeted around the pronator tears region or other suspected proximal compression sites. Ultrasound guidance is often employed for precision, especially in the pronator region, to ensure accurate delivery of the medication, and crucially, to avoid inadvertently injuring the nerve itself.
Ultrasound-guided injections for accuracy.
Increasingly common, yes. Oral steroids might offer temporary relief in some acute cases, but they are limited by potential long-term systemic side effects and are generally not a sustainable long-term solution for chronic compression.
Right. What about physio, nerve glides?
Physical therapy and nerve gliding exercises are certainly part of the conservative approach. These exercises are specifically designed to encourage gentle movement or gliding of the median nerve relative to its surrounding structures. The aim is to reduce potential adhesions and improve the nerve's mobility, effectively trying to free the nerve somewhat from its entrapment points. It's important to stress these are not about strengthening muscles, but about promoting nerve health and movement.
Mobilizing the nerve itself.
Precisely. There are several techniques patients could be taught. The handed wrist glide is a continuous sequence of about 6 positions, starting with a fist and a straight wrist, then opening the hand with the wrist still straight, then bending the wrist backwards, extension, then opening the thumb and spreading the fingers wide, then twisting the palm up towards the ceiling, supination, and finally, perhaps gently stretching the thumb downwards with the other hand. The goal is to create gentle tension and release cycles along the nerve's path from neck to hand.
A sequence of movements.
Yes. Simpler finger stretches involve just spreading the fingers out wide and holding for 5–10 seconds, repeating 5–10 times, to promote some subtle nerve movement through the carpal tunnel. The median nerve stretch can be performed perhaps with the arm abducted at shoulder height or with arms lower, focusing on a gentle stretch sensation by keeping shoulders back and down, maintaining a straight back, holding for maybe 5–10 seconds. This gently elongates the nerve.
Gentle stretching.
Gentle is the key word. The median nerve flighter is a slightly more advanced exercise, which creates a more graded tension through the nerve pathway. It should only really be attempted once symptoms are settling down from the prior exercises, and with extreme caution if any discomfort or worsening pain arises during the movement.
Go carefully with sliders.
Absolutely. And a crucial point for all these nerve gliding exercises: they should not be painful. Some mild stretching sensation or transient mild nerve symptoms like tingling might come and go as the nerve is mobilized, but patients should stop immediately if there is definite pain or clear worsening of their baseline symptoms, as this likely indicates too much tension is being applied.
Listen to your body. Don't push through pain.
Exactly. Other adjuncts for carpal tunnel syndrome have been explored, such as oral vitamin B6. However, research data supporting its efficacy is quite limited, and there are potential side effects like sensory neuropathy possible at high doses, so it's not routinely recommended. Low-level laser therapy and therapeutic ultrasound have also been investigated, but evidence supporting their consistent efficacy or cost-effectiveness is still developing, so they generally remain secondary considerations at best.
So stick to the basics mainly. Activity mods, splinting, maybe injections, nerve glides.
Those are the cornerstones of conservative management.
Okay, so when does surgery become the recommendation? What's the trigger point?
The critical juncture for both syndromes, the point where we pivot towards recommending surgery, is generally reached under a few circumstances. Firstly, if there's no measurable objective improvement after approximately 6 months of consistent, dedicated conservative treatment.
6 months of trying conservative options.
Roughly, yes. Or if the patient presents initially with very severe symptoms, for example, constant unrelenting numbness, profound functional weakness, or objective findings of significant motor atrophy, like visible wasting of the thenar muscles. Or, thirdly, if worrying electrodiagnostic results indicate significant nerve injury, such as evidence of axon loss or active denervation in the muscles. In these situations, surgical decompression is typically recommended sooner rather than later. The primary goal then becomes to prevent irreversible nerve damage.
Don't wait too long if there's nerve damage showing.
Exactly. The primary goal of surgery, irrespective of the specific technique chosen, is simple in principle: to release all structures suspected of compressing the median nerve at the identified level. This is particularly important in proximal median nerve compressions, where, as we've discussed, multiple compression sites can coexist, and therefore a thorough intraoperative exploration is absolutely vital to ensure nothing is missed.
Be thorough during the operation.
Absolutely. For pronator syndrome, PS, there are several potential surgical approaches. A wide release involves exploring and releasing potentially all the common culprits in that region, the ligament of Struthers, if present, the pronator teres muscle, often dividing the tendinous bands or releasing the deep head, the lacertus fibrosus, and the fibrous arch of the flexor digitorum superficialis, all in a single comprehensive procedure through a larger incision.
The belt and braces approach.
You could call it that. This offers the greatest theoretical likelihood of symptom relief, especially when the precise compression site remains somewhat uncertain preoperatively, effectively covering all the common bases. However, the downside is that it involves a larger incision, potentially more dissection, which could compromise the nerve's delicate blood supply, potentially leading to a longer recovery period and certainly a larger scar.
Pros and cons. What are the alternatives?
Alternatively, a limited decompression focuses on releasing only one or perhaps two of the most likely compression sites based on preoperative assessment and testing. This is obviously less invasive, potentially leading to quicker recovery and smaller scars. However, this approach carries a higher intrinsic risk of not releasing all the causative compressions, especially if there's a missed double crush component or an atypical site involved, which could unfortunately lead to persistent symptoms or early recurrence.
Risk of missing something.
Yes. Finally, there's endoscopic or mini-invasive release. These techniques target specific compression sites, like the lacertus fibrosus or the pronator teres, with minimal invasiveness. aiming to preserve the nerve's blood supply and reduce scar formation, often promising quicker recovery and less postoperative pain. However, these techniques demand specialized equipment and, crucially, highly qualified surgical teams with specific experience. They also inherently offer a more limited view of the operative field compared to an open approach, which potentially increases the risk of incomplete release or even inadvertent injury if not performed by an expert.
Needs specialist skills and tools.
It does. In terms of outcomes, surgical decompression for PS generally yields satisfactory results, with studies reporting good and excellent outcomes in up to 90% of elected patients. Some patients experience almost immediate relief, especially if the compression was purely mechanical, while others may take several months to recover fully, particularly if significant nerve regeneration is required. Patients with a very clear mechanical cause identified preoperatively, or those with an acute injury scenario, like that lacertus fibrosus tethering after a biceps injury, tend to benefit most reliably from surgery, often with quite dramatic and immediate symptom relief postoperatively.
Okay, that's PS surgery. What about the options for CTS?
For carpal tunnel syndrome, CTS, the main surgical approaches are the traditional open carpal tunnel release, OCTR, and the newer endoscopic carpal tunnel release, ECTR.
Open versus scope.
Essentially, yes. Open carpal tunnel release is a very well-established and generally simpler procedure, performed through a small incision in the palm, directly visualizing and dividing the transverse carpal ligament. While highly effective, it can be associated with certain potential complications like persistent weakness, pillar pain, that's pain at the base of the palm on either side of the incision, hypertrophic or sensitive scars, and sometimes a slightly slower recovery and return to manual activities due to the palmar incision.
Known downsides to the open approach.
Yes. Endoscopic carpal tunnel release was developed specifically to try and mitigate these drawbacks. It allows for much smaller incisions, either one or two small portals away from the direct weight-bearing area of the palm, and typically facilitates a faster recovery rate, often enabling patients to return to work and activity sooner. However, it is technically more challenging to perform safely and carries its own specific risks, primarily incomplete release of the transverse carpal ligament if the view is poor or the ligament is tough, or, more concerningly, potential neurovascular injury to the median nerve itself or adjacent vessels or motor branch, if not performed meticulously by an experienced surgeon.
Higher technical demand for endoscopic.
Definitely. In terms of overall outcomes, surgical decompression for CTS provides a long-lasting positive outcome, meaning significant symptom relief or resolution in the vast majority of cases, somewhere between 70% to 90%. Both endoscopic and open techniques are considered equally effective in the long-term results. The main difference lies in that early recovery period, where ECTR typically allows for an earlier return to work, on average perhaps about 8 days sooner than OCTR.
So long-term, both are good, but scope might be quicker recovery.
That's the general consensus. Interestingly, combining surgical treatment with routine splinting post-operatively has not actually shown improved outcomes in most studies, and may even potentially increase adhesions and stiffness. This suggests that early mobilization and careful post-operative rehabilitation rather than prolonged immobilization is likely key for optimal recovery after CTS release.
Get moving sooner rather than later after surgery.
Within reason, yes. And it's always important to recognize that recurrence of symptoms can occur after surgery for either condition. This is particularly true in those double crush scenarios where perhaps one compression site was successfully released while others remained unaddressed, or perhaps if the underlying systemic factors that predispose the nerve to compression in the first place, like diabetes or inflammatory conditions, are not adequately managed long-term. This really highlights the absolute need for that diagnostic precision we talked about and a comprehensive approach to treatment right from the very beginning.
It all comes back to getting the diagnosis right and considering the whole picture.
Absolutely.
That deep dive into treatment options truly brings it all together, from those earliest conservative steps right through to the crucial decisions around surgical intervention. So, thinking about our listeners, what does all of this mean for them in their daily practice? What are the absolute key takeaways from our exploration today into these intricate median nerve conditions?
Well, I think it's clear that while carpal tunnel syndrome is very widely recognized and frequently encountered, the complexities of these proximal median nerve compressions and their insidious potential to coexist with or cunningly mimic CTS really demand a heightened level of clinical vigilance from every one of us.
Be suspicious, basically.
Be suspicious and be thorough. This deep dive really underscores that a precise understanding of the median nerve's anatomy, Meticulous attention to the varied clinical presentations we've discussed and employing targeted diagnostic approaches are all absolutely crucial for effective patient care and for achieving optimal outcomes. Avoid jumping to the simplest conclusion too quickly. The findings in proximal median nerve neuropathies can span a really wide spectrum, from just subtle, vague weakness or fatigability that the patient might struggle to describe, right through to profound palsy or obvious muscle atrophy in late stages. We must always remember that diagnosis, particularly for PS, is often primarily a clinical diagnosis. There's a strong emphasis needed on those provocative tests that elicit symptoms and a painstaking effort required to identify subtle muscle weaknesses, comparing side to side.
Rely on your clinical skills.
Yes, that clinical acumen remains paramount, even when electrodiagnostic studies or imaging might initially appear inconclusive or entirely normal. This is particularly true in the earlier, more challenging, often intermittent stages of pronator syndrome. Don't let a normal EDX study completely rule out a proximal compression if your clinical suspicion remains high based on the history and examination findings.
Trust your gut sometimes, based on the clinical picture.
Within reason, yes, and pursue further investigation or referral if needed. Perhaps this discussion also raises an important question for us all to ponder. Whether separating these various proximal median nerve compressions into numerous, distinct, finely tuned anatomy-based syndromes, ligament of Struthers syndrome, Lacertus fibrosus syndrome, pronator syndrome, AIN syndrome, etc., is always the most practical or helpful approach in day-to-day clinical practice, given the often overlapping anatomical variations and the frequency of multiple sites being involved.
Interesting point, like lumping versus splitting.
Exactly. The idea of maybe a broader proximal median nerve syndrome might, in some ways, offer a more encompassing, perhaps more practical clinical perspective. It would focus more on identifying a compression in that proximal forearm elbow region rather than getting too bogged down initially in pinpointing the exact anatomical structure, especially given the commonality of the double crush phenomenon. It invites us to think more broadly about the nerve's health along its entire length first.
A regional diagnosis rather than a hyperspecific one initially.
Perhaps. Therefore, a critical message for you, our dedicated listeners, is this. Always consider a proximal median nerve compression. If your patient's carpal tunnel syndrome symptoms seem atypical, for instance, if their pain is predominantly in the forearm, or if they clearly have the Narnar eminence numbness, which shouldn't happen in isolated CTS, or, crucially, if their CTS symptoms persist or recur after a seemingly technically successful carpal tunnel release.
Look proximally if CTS isn't straightforward or fails treatment.
Absolutely. And conversely, if you suspect pronator syndrome based on a forearm pain and activity-related symptoms, but the patient also reports significant nocturnal paresthesia, that classic hallmark of CTS, then a coexisting carpal tunnel syndrome should certainly be considered and investigated thoroughly at the risk level. It's really about being a good detective and not just accepting the most obvious answer without probing further.
Connect all the dots.
Connect all the dots. Ultimately, the decision between conservative and surgical treatment requires careful, individualized consideration for each patient, balancing the potential benefits against the risks in their specific situation. We need to continue refining our diagnostic precision and our treatment pathways to ensure every patient receives the most targeted and effective care possible for these intricate nerve conditions, ensuring no patient is left suffering with unresolved symptoms simply because of a missed or incomplete diagnosis.
A truly profound thought to end on and a call for continued vigilance and learning. Professor Imam, thank you so much for sharing such invaluable insights and for helping us all become better anatomical detectives today. Your expertise has truly illuminated this complex area.
It's been my genuine pleasure. Thank you very much for inviting me.
And if you found this deep dive valuable, please do take just a moment to rate and share the Deep Dive Ortho with your colleagues. Until next time, keep delving deeper and keep seeking those aha moments in your practice.